We're going to start with a case of a patient that we saw in our hospital. The patient is a 54-year-old man who had known chronic hepatitis B and HIV, and he presented with abrupt onset of peripheral edema and increasing abdominal girth. He had also developed scleral icterus. His HBV and his HIV had been well controlled on an efavirenz LAM AZT regimen, so clearly an older regimen. And we certainly were suspecting that this was a case of a lamivudine breakthrough in a patient that had been treated on lamivudine for a while. He told us that his symptoms began a few weeks after staying on a farm in central Ohio, which is part of the Midwest of the United States and a major area for raising pigs, swine. And here are his lab tests. His HBsAg was positive, which we assumed, but his HBV DNA was negative, so he was still suppressed. His anti-core IgM was also negative. Hep C, both antibody and HCV RNA were negative, and he had antibody IgG to hepatitis A. The patient was very sick. He was listed for transplantation. He rapidly decompensated and died. And 1 week later, a test we had sent out for hepatitis E IgM was positive. So we think that this is a case of acute hepatitis E in the setting of HIV infection that caused this patient to decompensate, and it illustrates several things. Acute Hep E that was not initially suspected, the idea of acute on chronic disease. This patient did have a history of hepatitis B infection, and we'll talk some more about that as well. So these are the areas we will briefly cover. I'll start with some general observations about hepatitis E, and then we'll focus on some of the data in the setting of HIV. So hepatitis E is an enterically transmitted and zoonotic virus that's in the genus Hepivirus. It's a relatively small RNA virus, about 7,200 bases. There are 3 open reading frames. There are 4 genotypes that seem to be capable of infecting humans, although and I'll show you in a moment, there may be 5. And there's at least 7 or more total genotypes, but every year as people look, we discover new ones. This shows you the spectrum of disease in both humans and animals. Genotype 3 is the zoonotic form of the disease that's present in many animal populations, but particularly swine and deer, and those are probably in the United States the 2 main sources for infection. Of late, there has been 1 case report of transmission in the Middle East from a camel to a human, and that may represent another genotype, an animal genotype that can infect humans that had not previously been reported. There are also epidemic and endemic forms of the disease that are mainly waterborne without a clear zoonotic vector that infect humans. That's mainly genotype 1 and genotype 2. And we certainly wonder, there's been increasing reports of large outbreaks in avian and chicken colonies, and whether this can, in some cases, jump to humans remains unclear. So the human forms are clearly somewhat divided by geography and and location, and in part it's associated with the presence of either the animal vectors and exposure to those animal vectors through modern farming and eating practices, or it's related to poor sanitation that can be associated with contamination of groundwater. For example, we did a study with colleagues in the Nile River Valley and found that hepatitis E was contaminating the well water that people were drinking. So hepatitis E has been known for about 30 years, and for much of the time since then, this was the thinking, what I'm calling the old school thinking. It occurs only in resource-limited areas with poor sanitation. It has been associated with high levels of outbreaks in refugee camps and following monsoons in places like India and Bangladesh. And there's a very high mortality in pregnant women. But that's no longer what we actually think based upon more recent data. This is a disease that's found worldwide. The genotype is a very important feature of the presentation and location of the disease. It is not just an acute disease process, and the mortality in pregnancy actually varies by the region of the world you're in. Again, referring to studies done in the Nile River Valley, pregnant women rarely, if ever, develop fulminant hepatitis, which was the characteristic that had been originally described both in travelers to endemic areas and in India. This is the typical clinical presentation of hepatitis E. There's a relatively short window before one sees evidence of replication of the virus in serum and shedding of the virus in stool. You begin to see a peak in ALTs, and around the time that ALTs peak, patients become symptomatic. They initially have an IgM reaction, and that is replaced by an IgG reaction very similar to hepatitis A infection. But there's a second possibility, and that is that in some patients, particularly immunosuppressed hosts, such as those with HIV, that in fact the patient does not clear the virus, and that the patient continues to shed virus in stool and to maintain a viremia in their serum. And these patients actually have variable antibodies, both IgM and IgG. They'll have times where no antibody is detectable, that IgM will pop up, and that times you will only see IgG. But persistent through this is typically the presence of virus circulating in the blood. So what are the problems? Well, we have issues with the diagnostic tests. In the US, there's no FDA-approved tests. The tests that are available and produced as a group have been relatively unreliable with low specificity and sensitivity. And the duration of the anti-HEV IgM is relatively short as well. So if one doesn't catch the patient within just a few weeks of infection, you may not know that you were dealing with acute infection, but may be seeing a decompensated patient of unknown etiology that you may attribute to other sources. This is just a couple of studies, and I'll summarize them because it's too small to see the details. The first one is work in my lab where we did a comparison of results from two commercial anti-HEV IgM tests. The bottom line is that there's a very poor correlation in the results of the two tests, and so you end up scratching your head and saying which one is the correct answer. The CDC did a study of 6 different assays and basically found the same results with all 6 assays. Our laboratory did develop a confirmatory test that used ELISpot assay that does seem to fairly well distinguish between true positives and true negatives, but this is not a commercially available assay and is fairly difficult to run. And so it's something we use in our epidemiologic studies, but is not something that is going to be routinely available, at least at this point. In terms of virologic diagnosis, in the acute patients, there's a relatively short window of viremia. That always makes it difficult to make the diagnosis from blood. The stool has longer periods of shedding, but certainly if one is looking at retrospective study samples collected in cohorts and trying to determine the prevalence, very few studies actually collect stool, and laboratories in general don't like working with stool for virologic studies. My senior lab tech, who has been with me for over 20 years, has told me that if we ever do another stool study again, she's going to quit. The PCR is also not a commercially available assay. There are efforts now to create perhaps commercially available assays as this disease becomes increasingly recognized and in its importance. But this is our in-house laboratory proprietary assay, and this is a standard that is down to 10 copies. So we do have assays that can detect very, very low levels of virus. The top two lines here are detection in a patient, and in fact, we are able to detect to very low levels, but the period of viremia, again, is short, and even with such a sensitive assay, we often miss the acute period when following patients with HEV. I did help put together a proposed diagnostic criteria because of the problems of current assays. I think that in diagnosing acute infection, it's not easy to do. You probably should have ALT at least 2 times baseline, and then you can feel fairly confident if you use 2 different assays with an IgM with an HEV detected in stool or blood seems to be effective. ALT, again, elevated. We've used IgG with rising titers, a very traditional virologic method, and that seems to be effective as well. Or, as I said, the interferon gamma ELISpot is confirmatory but not available. And for chronic HEV, we use HEV detected twice over a 6-month period in either stool or blood or some combination, telling us that we have a chronic infection. So the clinical outcomes can be acute and chronic, and we have different classes of patients. Those that are immunocompetent tend to develop acute disease, but to date have not been reported to have chronic disease, and overall there's a low mortality. In pregnancy, acute disease can occur, chronic disease does not. Mortality is variable depending on where you're located, and we're not really sure of the other reasons. There's some evidence that genetic background may be a factor in that. Early childhood exposure, the local epidemiology of the disease giving some level of protective antibodies may be a factor. And the genotype may be a factor as well. Chronic liver disease, patients get acute disease. So far in those, we have not seen chronic disease, but the mortality rate is very high in acute on chronic, as the patient I described. And then in the immunosuppressed patients, which include those with HIV, but also post-transplant patients and patients undergoing cancer chemotherapy have both acute disease, chronic disease, and variable levels of mortality described. Here is one of the earlier studies talking about acute on chronic disease. Dr. Kumar looked at patients that had acute decompensation in cirrhotic patients and very high rate of acute Hep E that was described in those patients compared to those who had stable cirrhosis. So what about in the HIV infected patients? Well, this is a compendium put together during the past year of all of the reported data around the world in HIV infected patients, looking at reporting of both IgG and IgM positive and whether chronicity was described in that population as well. And I'm going to highlight, I circled here 2 studies. One of them was mine, the other one I'll show you, because how you find your cases, the tests you use actually affect the results. And part of the problem we're facing is that all of these studies use different methodologies and chose to do their screening in different targeted manners. And so the truth is we have some guesses, but we don't actually know the exact prevalence. And we can't answer the question at this point of are patients with HIV more likely than their local population to get a hepatitis E infection. This is one of the 2 studies. It was a study in the U.S. military, again, just for illustrating this question. They started with 4,410 HIV positive persons, followed for many years, but they focused on 458 who had ALT increase that was consistent with an acute hepatitis event. Of those, they randomly selected 194, and they did find evidence of acute infection in 4% during the follow-up period, and the IgG was about 3% using an older assay, one that has since no longer available, but also actually is probably not that sensitive. And so with this targeted testing, they reported some acute disease and relatively low rates of overall infection. This was a study from my group that we did looking at samples from patients who were enrolled in a U.S. national cohort of HIV patients who were being considered for liver and kidney transplantation. So there were 166 pre-transplant subjects. We used the 2 different assay methods for IgM and IgG using the definitions I already gave you. We also did PCR on all samples at baseline. None of those were available. None of those were positive. Stool was not available. And the overall rate of HEV positivity in those who were awaiting liver transplantation was 19.5%, and in kidney transplantation, 18.9%. In the liver group, 1% had IgM positive, definitively positive, and several more had possible, suggesting that in the liver group, some of the patients who were on the transplant list were there because of an acute on chronic decompensation. Most of them had other known liver diseases in the setting of HIV, particularly Hep C, some with Hep B. This just shows you the range of values. One is the cutoff on the signal to background ratio, and that in this group of IgGs, some of these were quite high titer, and in the IgMs, a number of these were possible as well. But in the kidney group, None of those represented what appeared to be an acute disease process. We recently have been looking at samples from a different cohort. This is a mix of Hep C and Hep C HIV-infected patients from what's called the DC cohort. It combines two large prospective cohorts, HEP-RES and HEP-PRO, that are part of the NIH-sponsored DC initiative looking at patients in the Washington, D.C., Maryland, and Virginia area in the United States. And the IgG positivity rate among the co-infected patients there, using the confirmatory methods I told you, was 16%. So again, it appears that infection is indeed quite common. This is about 5% higher than was described from non-HCV or HIV infected patients coming from that area. The cumulative risk is age-dependent of having prior hepatitis E exposure, and the highest risk in the older people, at least suggesting that either this is a cumulative risk or that this is a cohort effect, and that older patients had more exposures at some point in their life, may be related to prior representation of the sanitation or the cleanliness of the food supply. Now, Dalton first described chronic HEV in HIV, which was reported in 2009 in a New England Journal paper with patients that had persistent positivity of HEV RNA over time with varying levels of ALT during that time. A recent study looked at hepatitis E in the Ys and the Max, a women's cohort, and then a portion of a primarily men's cohort. They used an approach of doing HEV NAT testing, which is the PCR, with serologic evaluation of the positives, and you could see that among this, they found this large groups, they found 3 positive patients only, and then were able to go back to prior samples of those positives and focus on those patients. They did find one patient that had higher CD4 levels. Before this, there was a question of whether you had to have very low CD4s to have chronic infection. They had one patient of the 3 that had more than CD4s greater than 200. The significance of that is shown in this case that was reported, that patients will progress relatively rapidly if they have chronic E to what, if you didn't have the diagnosis or didn't look for Hep E, would have been defined as cryptogenic cirrhosis. And it's only the retrospective finding in a patient with HIV and cryptogenic cirrhosis that led to the discovery that, in fact, the liver disease was chronic hepatitis E infection. Can the chronic disease be treated? There are reports of the use of pegylated interferon, ribavirin, in immunosuppressed patients following transplant. About a third will clear if you reduce the immunosuppression. The data in HIV is less clear whether improving CD4 count will lead to clearance. We suspect it might. We don't know that for sure. Ribavirin is the main drug that has been used typically in a 12-week course. Here's a report of initial clearance from a multi-center transplant trial in immunosuppressed transplant patients, 90% plus clearance, but a number relapse, giving about just a little under 80% clearance with 3 months of treatment. There's, again, very limited data. This is a case report of the use of ribavirin in a chronic HEV and an HIV-infected patient. 39-year-old man treated with lopinavir, abacavir, lamivudine. He ate raw pork, liver, sausage, and he had a very low CD4. His HIV was well controlled, but he was infected chronically with HEV genotype 3. He was jaundiced, decompensated. He was treated for 12 weeks. The viral load dropped, and the patient cleared 1.5 months post-treatment. There is a vaccine available. This one is not. This was the first vaccine that was reported. It was made by GlaxoSmithKline. It had a very, very strong study result in terms of protection compared to the placebo arm versus the vaccine arm. And then the development of this was stopped because SmithKline decided that this was not worth pursuing. The people who needed it wouldn't buy it. Subsequently, in China, another vaccine was developed. It is called Hecalin. It is for sale in China only. It appears to be very effective and at least durable out to 4 years after the vaccine is given, but it is not available in other places and has not been studied elsewhere. So Hep E after exposure can lead to clearance, which is a result of an innate response, a T-cell response. Clearance requires innate immunity, memory T-cell responses, and the development of neutralizing antibodies, which appears to lead to long-lived immunity and may be the modulating factor in patients that are exposed early in life. Acute HEV in immunocompetent patients often or always leads to resolution as far as we know. In immunosuppressed patients, there may be resolution, but some patients in pregnancy is an immunosuppressed state, may lead to acute liver failure. In the setting of impaired T-cell responses, I didn't show you the data on quasi-species variability in the presence of genotype 3, at least, may lead to chronicity. So in conclusion, HEV is prevalent in Western countries where it was previously unsuspected, and the prevalence in HIV infected may be higher than in the general population, though we really still are not completely sure of that. It is clearly underdiagnosed in HIV infected patients for a variety of reasons: low clinical suspicion, poor assays, and low availability of those assays, even though they are poor assays. There is not a huge risk of chronicity, it appears, but when it occurs, it could be associated with progressive liver disease. Things we don't know: are HIV patients at the greater risk? I've mentioned that already. I have to wonder, have we misclassified HEV as drug-induced liver diseases or other etiologies in some HIV-infected patients? How does CD4 affect risk? Is it really more common, less than 200? How are humoral titers, avidity, CTL response altered in our HIV-infected patients in a way that, how does that affect this chronicity process? We don't know. And finally, the important clinical question is, there is a vaccine available in China, but we really know nothing about both the efficacy of that vaccine, the response to that vaccine in patients with HIV, and whether it would be protective in our patients. Thank you.